Hello, everybody. Welcome to another AFR EMS case study. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today I'm joined again by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
Welcome, Doc. And we're joined by Captain Rob Laprice, 7-8 extraordinaire.
Hi,
Welcome,
Chief.
Rob.
Thank you.
So we have an interesting case today to discuss. It was a PEDS near drowning for Rescue 9 and Station 9 Albuquerque ambulance. They were dispatched to a 14 Echo at a single family dwelling, and it was a 2-year-old male drowning. Rob, at 7-8, I know you weren't on this call specifically. We're going to talk about it on behalf of the providers. But just talk with us about being 7-8, who's typically assigned to high acuity calls like this, and what you're thinking when you're en route to that call, and what your role is when you first arrive on scene.
So my thinking on a call like this right away is, how old is the kid? I'm already thinking weights, and I hope the crew is thinking weights as they roll in, and then expect the worst. So if it's a drowning, I want them to obviously remove them from the environment, remove them from the pool, get on the airway right away, get on the chest right away, start to ventilate, oxygenate, know their epi-dose, get access. And I don't want them to be scared and run. We want to work it. And that's really my role. I'm going to get there and make sure that those items are coordinated pretty well. That's what I want to see.
Perfect. Okay. In this particular case, this was a 2-year-old male, was weighed at about 9 kilograms, was crying when our crews first arrived, but wasn't really interactive, not really responsive, still had some pink skin. Sounds like the family described that the patient had jumped into the pool with a flotation device and had been submerged maybe about 5 minutes or less. The family member pulled the patient out, started CPR, and was initially unresponsive and not breathing. And after about 5 compressions, the baby vomited some water and was blue prior to our arrival, but it sounds like was not in cardiac arrest when we arrived. So talk with us a little bit, Doc, about drowning and aspiration cases, and how, even though the patient presents awake and otherwise looks okay, what should we be looking for long-term for a patient that was submerged?
Yeah, so this is one of those calls where you're thinking the worst when you're on your way, and you get there and you're happy to see kind of a crying, somewhat interactive baby when you get there. But especially the fact that this one had potentially drowned in a pool. That pool water has chlorine in it, and it sounds like with him vomiting water, he had definitely aspirated some. And if you get to these calls where they're like, oh, okay, the kid's fine now, everything's good, he's breathing, he's pink, and you get a good initial set of vitals, that doesn't always mean that everything's okay. I would be very cautious about even entertaining the idea of a refusal here, because that chlorine, as it gets in the lungs, can cause kind of a delayed inflammatory reaction in the lungs. And a lot of times initially, these kids may not be hypoxic or in any respiratory distress, but over the next 24 hours, there's like a pneumonitis that can blossom as a reaction to the water that they inhaled.
That's great to know in terms of, let's say if we responded out to a kid after the fact that maybe they didn't call us for the first time, maybe they had been submerged and maybe had taken in some water, and then the next day or 2 days later we respond and they have a different presentation. If we were to arrive to that call, how would our treatment be geared for treating that kiddo?
So I always like to emphasize with our pediatric patients, and I know you know this too, Rob, when we're talking about any respiratory distress in a child, it's so important to look at their chest to evaluate their work of breathing, how fast they're breathing, and if they're having any retractions, and then get a good history, figure out why. And in this case, you would probably hear about them aspirating some water. Maybe not everybody puts those pieces together, but if you see that work of breathing, that a lot of times you actually have to look for, because if you're just looking from their neck up, they're going to fool you. You've got to look at their chest.
And Rob, you were able to talk to the provider on this specific event about it. Tell us a little bit about what they told you, what they saw, what they did.
This crew did an exceptional job on this call, Chief. They were able to slow it down after it wasn't a full drowning. They were intentional, methodical, and just chronological with their care. They provided oxygen. They treated for hypothermia. They considered all the possibilities. They got the transport to the right facility, and overall, just an exceptional job, I feel. I mean, they hit all the marks. And there's always a chance with some crews, and we shouldn't get into this, whether it's whether the call's a choking or a drowning, and we get there and it's not that, it's just time to slow it down a little bit, consider all of our options, do a good assessment, and consider possibilities and treat for those as good paramedics.
Another important point about this is, like, going back to the work of breathing, they gave oxygen. Just because the SATs are normal, especially in a child, you're not treating a number, you're treating their work of breathing. And they were really smart here to actually administer oxygen, even though the number was fine and acceptable, anticipating a little more increased work of breathing there. The other thing they did, I thought that was really good, was assess for trauma. Anytime there's a pool involved,
Yes.
it could be a diving injury or some sort of traumatic injury, as well as the drowning or that led to the drowning. And they did a real thorough assessment here as well.
And if you look at the numbers here, the respiratory rate was 36 and the CAPNO was 30. So the kiddo was breathing pretty good, blowing off a lot of CO2, which makes you pause and be like, there's more here.
Yeah.
You know?
And, on the heels of some of our last discussions in terms of high-risk refusals, that would be one where at first glance, you look at that patient, they're breathing normal, those vital signs are kind of within those parameters, not thinking through what could happen 24 to 48 hours later, I think is key to getting them to definitive care, which this crew did, which was a fantastic job. We talk about the luxury of having the follow-up on patients after the fact, so the stuff that we don't see and then kind of the end result. How did this patient end up when they got to the hospital?
So this is actually exactly what we've been talking about. This child, when he got to the hospital, was actually showing a bit of a respiratory acidosis from the aspiration. Pneumonitis is what we called it. He ended up with a 3-liter oxygen requirement as that kind of reaction kind of blossomed in his lungs and made ventilation a little bit more difficult. But luckily, his mentation stayed fine. He stayed in the hospital for a day or two on some supplemental oxygen until his lungs healed, and then was able to go home.
And that just confirms the great approach and assessment and treatment these guys did. They kind of nailed it. They could have been laissez-faire about it, got a refusal, just by how they talked to the parents and how they approached the situation. So they were serious about it, and they did a great job.
So the high acuity response for 7-8 is only one piece of the puzzle. There's always that education, the follow-up, and things like that with crews after the fact. Not in this case specifically, but just in general with peds near drowning or drowning cases, or if it was a cardiac arrest. Talk with us a little bit about how you approach those crews after the fact to do kind of a tailboard or a debrief of the call.
I just like to get them all together. I like to start positive, look at what we did that was great, and then I'll just talk about where we can improve. And it's usually with weights or drug dosages or delays in the airway that we hope there wasn't any. Just all the finite details. We're really great at these kind of calls, actually. Cardiac arrests, drownings, we're great at them. But there's always some room to improve. And I think there's always points of learning available.
And it's our comfortability with these calls, right? They're rare, thankfully. So it's always ups the anxiety a little bit when you're responding to these high acuity calls on the peds. PD stat, Doc, we talked about that a little bit. Like, how will the integration of PD stat, first, what is it? And the integration of that into our web-based app, how will that help providers?
So it's actually a pediatric dosing app that I actually use all the time in the hospital. I'm very excited to incorporate it into our pre-hospital
And that says
guidelines.
a lot.
Yeah, I rely on it myself. I double check everything. But you can either enter the child's weight or the child's age, and it'll give you the Braslow color depending on what you know about the child, and then your doses, not only your milligram doses, but also your milliliter doses for any of our common drugs that we use, perfectly aligned with our guidelines. A really kind of one-stop shop for peds dosing that should help, because I know I'm terrible at math, especially even in the best of times I'm terrible at math, but in stressful situations, even worse. And so it's nice to have a reference like that that's reliable.
We're hopeful that'll be a great reference tool. We're asking folks not to download PDStat separately right now. We want them to wait until the integration into our current app, which hopefully after the beta testing, we should have by the end of the year. And then that'll be a lot easier. We still have the the Broslo tape and all that's available, but I think for dosing, it just makes it a lot easier at 2 a.m. on a stressful call to help us out.
These are great calls, Chief, to pre-plan on. Like, I think pre-planning is our opportunity to get like ahead of the game a little bit and not be so cold walking in there. Like, we can figure out Pete's weight, the situation, whether it's an adult choking. Like, we can sort of visualize it in our heads with our partners or our truck or our crew. And I think it's a great opportunity too.
Such a sign of maturity, because I think if you can always try to stay in your head one step ahead of your patient, I always ask myself, if this patient was going to get worse, how would they get worse and what would I do about it? And if you can anticipate that, then it doesn't come as such a surprise and you're not caught on your heels. So like this kid, if he had gotten worse, positive pressure is always the answer for any kind of aspiration. And so bagging. But being able to anticipate that and think through it and then not be surprised.
As an officer, to get everyone on the same page.
Yeah.
Before, like, if I'm on a pumper, I'll turn around and be like, hey guys, this is 2-year-old drowning. Here's the plan. Here's how we're going to approach this. And everyone's shaking their head in the back, but I know they already have a vision because I just gave it to them. I suggested it. And that's how it works. I think that's how we're better.
Yeah, and not only en route to that call when you're going to kind of prep before you get there, but I think it's an opportunity. We always talk about the kitchen table and the training opportunities there, even before you have this call, is to just bust out a guideline that we haven't used in a while, or like a high acuity situation that might throw everybody for a loop, and let's just talk through it and train on it before it becomes reality.
That is a true sign of success. When I have people come to me and say, hey, remember you were talking about this airway procedure or this trachea? Well, I had that call, and the conversation didn't start out with a call or a bad outcome. It just started as training. It's really fulfilling when that happens, just to front load that training.
Absolutely.
Yeah.
Well, I appreciate you both taking the time to come talk about this case. This is a perfect example of great treatment, great care leading to a good outcome. That baby is now home and healthy. That's to the credit of our crews and their work. That's it we have for today. But if you have cases that are interesting or you just think other people would want to hear about, use our SharePoint tab. You can submit it, reach out to any one of us, and we can set it up. Also, just like today's case, if you're not comfortable coming to talk about it in front of everybody, we're happy to discuss your case for you. But look forward to hearing from everybody. And until next time, thank you.